day-to-day neuropathology practices at Shanti Pathology Lab. Sometimes we come across very rare and unusual cases, and this time we had endolymphatic sac tumor coming to us from the same neurosurgeons, that is Dr. Yogesh Vargantwar and Dr. Sushil Shinde, Orion Hospital, Aurangabad, within a span of 2 years. Case 1 is a 61-year-old lady who complained of hearing loss and loss of balance. She underwent a MRI that revealed a heterogeneous solid cystic lesion in the left jugular fossa extending into the left cerebellar parenchyma laterally and measuring about 4.8 into 3 into 4.6 centimeters, causing effacement of the jugular bulb. This is the gross we received in lab, and these are the areas of hemorrhages. Histopathology was very typical. The tumor was predominantly papillary in architecture with few glandular areas with central fibrovascular core. Now the lining of this is simple cuboidal to tall columnar ciliated. You can appreciate these cilia here. No features of malignancy were present, such as nuclear pleomorphism or mitotic activity. So we rendered a diagnosis of endolymphatic sac tumor of the left CP angle. This is a case 2 of a 42-year-old man who complained of hearing loss. He had been treated for idiopathic left facial palsy for 6 years and he had a past significant history of chronic mastoiditis in the childhood. His MRI revealed a hypervascular mass measuring about 37 into 27 mm with extensive mastoid and jugular bulb destruction and involvement of the left 7th and the 8th cranial nerves, which correlated with the 6 years of facial palsy and conductive deafness. Now, in this case, the radiologist rendered a few DDs such as schwannoma with cystic change, and due to the spoke-like enhancement, a diagnosis of paraganglioma was favored. So these are the gross which we received, and we also received bony fragments here. The tumor was invading the bone, and this is the tumor proper. So microscopy again was very typical and confirmatory. The tumor with papillary architecture and bone erosion was present. You can appreciate the lining epithelium is tall columnar and ciliated. So these are the cilia. We went ahead with immunohistochemistry in this case, and it was VIMENTIN, EMA, CK7 and PAX8 positive. Usually IHC is not required for diagnosis of this tumor. So one needs to know the differential diagnosis just to finish, complete the profile. It's the choroid plexus papilloma, jugulotympanic paraganglioma, metastatic renal cell carcinoma, metastatic thyroid carcinoma, and the middle ear adenoma. These are very marker specific and location specific, site specific. So endolymphatic sac tumors are very rare, locally aggressive tumors of the endolymphatic sac. Early detection of these tumors is critical because early surgical intervention may prevent further hearing loss. These tumors do not metastasize but are highly locally aggressive. Now, this tumor was first described in 1989 by Dennis K. Hefner, an American physician. And before this, the endolymphatic sac tumor was misdiagnosed as a choroid plexus tumor or adenomas or metastatic adenocarcinomas involving the CP angle. The median age group of this is 30 years, whereas it may range from 11 to 71 years. These patients present with hearing loss. In 95% of cases, it is acute and it is gradual in the remainder. Tinnitus is caused in 92% of cases and 62% present with vertigo and disequilibrium. Oral fullness in 29% and 8% present with facial paresis. Endolymphatic sac tumors are often associated with von Hippel-Lindau syndrome in 11 to 16% of patients. And whenever VHL is present, almost 30% of cases show bilateral involvement. Imaging findings. These tumors are seen arising from the vestibular duct involving the endolymphatic sac or the duct, and therefore the lesion is located in the posterior or retrolabyrinthine petrous bone. On CT scan, these appear as erosions in infiltrative or moth-eaten pattern, and these are often show intense enhancement. On MRI, these are hyperintense on T1 and heterogeneous signal on T2 weighted images. A spectrum of differential diagnosis is given on imaging findings usually, that is jugular paraganglioma, cholesterol granuloma, meningiomas, and bony metastasis. Treatment and prognosis. Surgery is the primary choice of treatment and wide excision is done as these tumors are locally very aggressive. Skull-based approach is usually taken and preoperative embolization is done in cases of massive bleeding. Now the second case, that is of the 42-year-old man, this man received almost 8 units of blood because of the high vascularity. And in recurrent cases or those with positive margins, radiotherapy or radiosurgery plays a role. Thank you very much. I hope you like this case.